Give a few slide introduction to why are we doing this topic of strong English? Why are we planning this topic? Anyway, so patients and trials. So this is a nice quote which I got, which previously used to hang in e-ward. I don't know if the registrars or consultants have seen this. It's by Mahatma Gandhi. A patient is the most important person in our hospital. He is not an interruption to our work. He is the purpose of it. He's not an outsider in our hospital. He's a part of it. We are not doing a favor by serving him. He's doing us a favor by giving us an opportunity to serve, to do so. So, that's the motivation behind this today's ideas talk. So if one looks at this in research, we are because we use mainly research. How do patients get involved in research? So one is they can tell you ideas for research. What do they think are the priorities for research? Ideas and priorities. What do they think? Patient means like who should the patients, whom do they think will be the patients we involve in research? We have an inclusion exclusion. They may have a slightly different idea. What intervention should be used? They may want some other interventions from what we think. Whom should we compare the treatment with? Patients and caregivers may have a different idea. Lastly, the outcomes. What outcomes we want? Healthcare workers want usually fixed metrics which we can measure, evaluate, statistically compare. But patients may want a slightly different set. So the first one is this James Lind Alliance Guidebook. Just to show you that the PDF is there. This one looks at priorities. So, from the patient's perspective, what are the priorities for research? So, somebody wants to know. This book has given talking to various patients. What are the research priorities one should do? If you want to know from patient's perspective, this is a good reference. It's called the James Lind Alliance Guidebook. The second one is also on priorities. I told you ideas are priorities. This is called the REPRAISE guidelines. So, reporting guidelines for priority setting. So, when you're making what should be the guidelines, what should be the health priorities, they ask carefully have patients and caregivers been involved in these priority setting. Not only patients and caregivers, obviously healthcare workers, policy makers, economists should be there. But this one gives an idea about that. So this is reprise is for priority setting. Have anybody heard of this one? COMET? COMET is for outcome measures. So if you have, for example, MACE in cardiology, major adverse cardiac event, it's a combination of many things. But that is set by a group of cardiologists. So that any future cardiac trial should look at MI, stroke, cardiovascular death, 4 or 5 other things. So if you have those, it's part. So COMET is an initiative look at various subspecialties across the healthcare and can we have outcome measures which are fixed so that anybody doing a trial in that specialty should measure those outcomes that you can compare across trials. So this COMET involves patients as well. So patients and public healthcare professionals should be involved in creation of outcomes. So if you want to know what outcomes you should do for your trials, not only RCT, and you want to know what will be relevant to patients and caregivers, the COMET will be a good one. Now, there's another one called GRIP tool. Now, you can see there are plenty of checklists and we can get lost in this soup of checklists. The overall process, that is from the idea to study design to PICO to analysis, is a GRIP tool to see whether patients and caregivers can be involved in the whole process. So, it's an overall sort of a tool. The next one is called precise checklist. This precise checklist looks like interventions. Okay, I want to do PICO, and patient intervention. Some interventions are complex. For example, social interventions. There will be an educational component, there will be an electronic component, there will be a government policy component. So the intervention itself is made up of 2 or 3 different parts, especially for staff people. Some interventions are quite complex, and the whole thing together is the intervention. So this precise checklist is meant for complex interventions, and also, but they do have a question while developing the intervention for patients and caregivers involved in developing this intervention. What Anuka is going to talk today is called the ideas framework. Idea framework is not only for complex intervention, all interventions. The people remember patient intervention, control outcome. Here we're talking about the intervention for patients and caregivers involved. So her talk is going to focus on the intervention side. Of course, you're going to take a lot of this, a very detailed talk, but it's on interventions, development, how much of patients and caregivers involved. The last one is reporting of interventions. So this checklist is called a tidier checklist. This tidier checklist is for RCTs. All RCTs, if you look at the consort checklist, one of them will be talking about interventions. But actually, the intervention could be given in great detail for somebody else to replicate. So most randomized controlled trials will use this checklist to see whether they have reported the intervention very detailed. That's called the tidier checklist. So, however, the tidier checklist doesn't give anything about the patient being involved in the intervention, patient or caregiver being involved in that. So, Anuka's talk is going to be focusing mostly on this one, ideas framework, which is on patient and caregiver involvement in intervention. So, that's just the background of what today's talk is about. So, I'll stop the talk here now and I'll hand over the talk to Anuka. Thank you very much, Anuka. You put a lot of hard work into yours. This one?
Yes. Today I'll be talking about ideas framework. As sir has said, it's about how to report patient and caregiver involvement in a healthcare intervention. We'll start with a case. So, this for the registrars and interns. So you're presenting this patient in Grand House. The 50-year-old man, a professor with a cardiac problem, HOCM with atrial fibrillation, with diabetes and hypertension. And as per the guideline, for this treatment, he is on a blood thinner called oral anticoagulation. So he's on this medicine for 1 year, he's not compliant on that and has come with a complication of a TIA, which is like a minor stroke. Now, because of this compliance and this complication, your professor asked you to find an effective tool to help you manage this disease. The patient and the wife suggest that we want something in which patients are involved in the development of the tool. So you are faced with two questions. Is there an effective tool? And how do I assess the involvement of patient and caregiver in an intervention? Now to answer this, first, how do we assess the patient and caregiver involvement in intervention? Is there a reporting guideline? So this is the guideline we serve as introducing now, ideas framework. This was published in the Journal of Clinical Epidemiology. This has a 14-item checklist with 5 domains. So these are the 5 domains: purpose, theory, framework, population, mode of intervention, output, and impact. Now, to answer our question about the tool and how the patient involvement was there. So today I'll be talking about 2 studies. One is development of a complementary encounter and patient decision aid. Now, decision aid is an online tool that will help you explain the patient to understand his disease. So the first study is about how the tool was developed and some of the terms which I'll be talking about would be, one is shared decision making. So we know in medicine, it's always a collaboration between the clinician and the patient. And this collaboration is called shared decision making. The second decision aid, which we'll be talking about, is an instrument which will help you in shared decision making. So here there are 2 decision aids. One is a patient decision aid. So this patient decision aid is to use before a clinical encounter. That is, before you meet your doctor, you go through the aid and then you can ask questions to your doctor. Second is an encounter decision aid. That is, when you are in the consultation with your clinician, when you're talking with your doctor, you can use this and you can plan a treatment plan. So these are the 2 words, terms which I wanted to explain: patient decision aid and encounter decision aid. Now, this is a study we'll be first looking at development of complementary encounter and patient decision aid. And how effective was the aid? We will look at in a subsequent study, which is a cluster randomized control trial. This is the outline of the talk today. I'll be looking at patient and caregiver reporting using the IDEAS framework. I'll be looking at the effectiveness, which was tested in an RCT. And today's focus would be on the IDEAS framework. So coming to the checklist, 14 items and the 5 domains. The first domain is purpose. So I will be covering both the study, the development study and the RCT. So the first item is define the role. Have they defined the role of the patient and caregiver? That is where they're involved in identifying the intervention or designing the intervention. So in this study, they were involved in the development of this decision aid. So they were involved in the design, conduct, and analysis of the research study. So designing, subsequent prototyping and refinement, feedback and usability testing. This was done for the decision aid. And in the RCT, they have given a separate column with patient and public involvement. And one of the stakeholders were the patients, and they were involved in the design, conduct, and analysis. And also, they have mentioned that they were involved in the changes in the outcome measure used, recruitment of the script strategies, and the length of the survey method. So, both they have reported the patient involvement, at least the purpose well. The second is specify the type of the intervention. So the intervention can be preventive. For example, a lifestyle changes to prevent a disease, or it could be therapeutic, exercise to control your sugars, or could be a health system intervention. So here it was a health system intervention. It was a decision aid tool to help your disease. Outlines, factors or criteria considered regarding the intervention. So we know that atrial fibrillation can cause stroke, which has lot of disability and is fatal. And if you give anticoagulation, blood thinners in this particular group of people, it will prevent a stroke. But it is not a blanket guideline for everyone. So we do something called a personalized risk stratification. That is, if a patient whose risk is less and benefit is more, they are prescribed anticoagulation. Now, for this concept, they have in this study they have mentioned that the criteria they had put for the intervention was, one is they wanted to improve the shared decision making to improve health outcome. So they have decided encounter decision aid. So this is during a visit, it facilitates your communication. It will help the provider elicit patient value. So it will help them to finance and other things which we consider. This will help in coming to a decision with them. So this is an encounter decision aid. Second is a patient decision aid. So the patients are prepared before they come to the consultation with the clinician. So this helps preparing the patient, giving education about their disease and establishing the value. So some patients may want to discuss about cost. Some patients may want to discuss about follow-up. So it will help them establish that. Now coming to the fourth item, theory of framework used to form the intervention. Now, according to the International Patient Decision Aid Society, the gold standard to make a methodology is an iterative user-centered methodology with pilot testing. In this study, they have done a user-centric design. They have done an iterative design process with refinement and design, and they have done user testing. And they have not mentioned any other framework, but it's probably adequate for the study development they have planned. Population, define the inclusion criteria. So the demographic, clinical criteria, expertise, and the experience of the patient. So in the first study, which looked at the development of the aid, they have used both patients and caregivers, but they have not mentioned anything about the clinical or the experience criteria. They have not mentioned anything else. But in the RCT, so they have used this RCT to compare this decision aid versus the usual care. So in the RCT, the inclusion criteria was patient should be more than 18 years old, should have a non-valvular AF, that is one kind of heart condition, should have risk factors. So the CHAD-VASQ score, we know for treatment more than 2 for men, more than 3 for female. So at least they should have, apart from the gender, another risk factor, and they should be eligible to receive anticoagulation as justified by revision. It is a very adequate inclusion criteria. In the study, they had two types of cohorts. They looked at people who were started on anticoagulation, and they looked at people who were already on anticoagulation and required anticoagulation. So they had an initiation cohort and they had a monitor cohort. And for the initiation cohort, the criteria was no previous anticoagulation, or they should be taking only antiplatelet. They should not be on any anticoagulation. More than 6 months, they have discontinued anticoagulation, or it is started within 60 days. Anticoagulation started recently within 60 days. So they were the people criteria in the initiation cohort. Monitor cohort are people who are taking anticoagulation for more than 60 days, and they have either one of the following criteria, like they have some problems with the anticoagulation. Either the value is not correct, INR is not correct. If they have either perceived or actual side effects, or affordability cost is issue, or they have some previous contraindication has changed. For example, epic sub-ban use in renal dysfunction or obesity, and now the criteria has changed. Or the medical condition has changed that will affect stroke prevention. For example, the renal parameters are going up, or there's a stent placement. So those were the people who were included in the monitor cohort. Now the sixth item was describe how patients were caregivers were identified and selected. So you can identify or you can screen them through a social organization or network, social media, hospital. So in this study, how the patients and caregivers were identified is not provided. But in the RCT, they have looked at all the patients who were scheduled for a clinical appointment. So they have a clinic where they look at atrial fibrillation. So all the patients who were scheduled for the appointment were screened for the study. So this was a recruitment, and they had done either in person, via telephone, via email, or via television. Specify the number and describe the characteristics of the patient and caregiver involved. So in the developmental study, they had one panel which was one panel for the designing of the aid, which included 10 patients and caregivers. They had another developmental team in which, apart from the other expertise, there were 51 patients. They were from all, they were around six institutions from around the place. But however, the details of the the clinical details or the healthcare income or the literacy, those things are not present in this study. But however, they have said for the RCT, they have included that in the RCT. This is what they have given for the 51 patients who were included. So if you look at it, it's a predominant, mean age is around 66 to 62. Females are less. It's a predominant male population, 11.7 to 29.4%. And it's a predominant white population. So this is actually the population which is there around that institution. So the patients are predominant white and male. And this is how they were involved in the participation of the prototype interaction. So the purple is the people who observed and were involved in the interview. These were the people who only observed, and these were the people who only were there the interview. So in the final, they had like 4 groups. They had a group which had no care. They had a group which had both the tools. One group which had only the patient decision aid. One had the encounter decision aid. So this is how they were distributed. Now from the RCT, they have given a detailed patient characteristics. So they have looked at demographics, health services and insurance, health literacy, numeracy. So any particular preference for numerical digital literacy, because they felt that this is something which would help or which would limit them using an online aid. So this was the baseline characteristics. We'll look at it in the RCT. The domain D, describe the process for involving the patient and caregivers. So this was the flow diagram for the design. So they had a team which included patients. They had actually looked at all the existing design aid, made a prototype, made revisions, and they did usability testing and made revisions subsequently. So it was an iterative design process. They had semi-structured interviews, observations, and internal testing. And the interviews, they had used journey mapping approach. And some of the interviews, they had done a development of teams using an inductive approach. And in the RCT, how they involve the patient or involve the patient were through the surveys. They had outcomes, everything was measured by a survey. Specify the frequency, that is how frequently have they met. So in the developmental aid, they have not mentioned anything about the frequency. In the RCT, This was a flow chart for the RCT. It was a randomized control trial. We'll come to that. They had a four-arm. So they had immediate and post-encounter survey, 6 months follow-up and a 12 months follow-up. So they had actually met post-encounter 6 and 12 months. Specify the duration. So the developmental aid study, they have not mentioned how long they took to make the study. But for the RCT, the final follow-up for the secondary outcome was for 1 year. The item 11, the form of remuneration. So in either of the study, they have not mentioned if any financial or any other gift card or any other support was given. That is not mentioned. The fifth domain, output and impact. Now, what is output? The output is the interventions, the suggestions given from the interventions identified. If they suggest this intervention is good, so that is output. Anything on what they prioritize or any feedback of the design. So I'll give an example. So output is something which is to improve or refine the design. For example, if they identify new intervention which can be used or refinement of the previous interview or a feedback on the design. So in this study, some of the outputs they had given was the development team was involved in identifying a need for a new personalized developmental aid. They were involved in prototype and refinement, data collection, and feedback and usability testing. Now, some of the outputs which they had given was, so they felt that the cost comparison was very important. So they wanted that to be there in the patient decision aid. And so they noticed that there was some usability issue with the initial form of the decision aid. So a lot of patients were skipping some portion of the tool and they were not able to navigate through the tool. And so initial tool had some arrows, they had to follow them. So they realized that people are skipping it, they are not able to follow. So this was some of the output they had given. Second is impact. What is impact? As a result of the output, some new changes are made or new intervention made. So that is the impact. So some example of the impact is either some modification which is made or it can be a personal benefit impact. The patient become confident in managing a disease or the research skill or a sense of accomplishment. So here one of the impact was they had developed the decision aids, both per patient and encounter decision aid. Second impact was, this is actually taken from the study, they felt that this improved their conversation with the provider, especially the visualized and the personalized data, they were very actually happy with that. They felt that improved their conversation. I'll go through some of the output and impact. So a lot of patients felt that they feel isolated or lonely when the diagnosis is raised. So the calming, reassuring language like you can live with this or you are not alone, they found it very reassuring. So in the final version, there's a message saying you are not alone and they present the statistics that 2.7 billion Americans live with AF. Second, output was the initial version had a text box in which patient can write the questions to the clinicians. So patient feedback was this is not needed. We want something called a frequently asked question. The clinicians had a concern that if they put a text box, they would give their personal data and that would be concern for privacy. So in the final study, they had an interactive list of commonly asked questions for the clinician. They could download it, the personalized list of questions, and then if they want, they can give their comments on that. So that also eliminates the concern for breach of privacy. So that was another one of the impact. Initial version had only one content for both new patient and for experienced patient. So they felt that this is not needed. We are experienced, at least people who were on follow-up, they felt that this is not necessary. So now, in the final patient decision aid, that is the one they see before they meet the doctor, you can choose is it experienced or naive version of the PDA. In the experienced version, the language is clear. Take a review approach. I'll give an example. So this is one of the patient decision aid. This is the left is a naive and this is the experience. When you start off, it talks about tell me about what it means to have atrial fibrillation, stroke prevention, meeting with my captain. But when you review, it comes where do we start? Review my situation, reviewing my options, meeting with my captain. So they could actually choose. This is the second thing, things to reflect between the appointment. So the native one was, I hope my medical leave would be. But in the review one, it was what changes have I faced because of my condition, or what changes have I faced because of my treatment. So the review, the wordings were different in the new and the review ones. This is things to discuss with the care team. So that for the first patient, it was understanding my situations, knowing my options. But for the review, it was managing my care, responding to problems. So it was worded in different ways so that they found it more useful and they could actually use it better. Other issue they had found initial was a user interface details. So the first phenotype which they had, it was a linear, post-linear detail. So they had to go like this, then come to the next one. And they found that people finding it difficult to navigate through that. So then the final version was a non-linear. You can either read like this or this, that increase the acceptability. So this is the older version. So you have to read, I'm not sure if it's clear that. So risk of stroke, how many people will have stroke, how many people will have fatal stroke. So you finish this. Then the greens, this is the fatal stroke, minor stroke. So you have to go like that. So because of that, in the current version, it is changed to a non-linear. So you can either read it like this or read it like this. They made it simple and easy for them. So this was actually part of the feedback which they had. Some other things which was not they have not taken from the patient feedback. One was initially they had put all the strokes. But then based on some study, they have changed it to only fatal and disabling stroke. So it's easy to see. This easy to see. So among the so many people, this many people can get stroke. But if you take a medicine, you come down on a risk by so many people. Second thing was, this was based on some other study on the type of icons. Initially, they had smiley faces, the happy smiley and the sad smiley. Then they changed to gender-specific icons, so that is easy and more relatable for the patients. So the last item was describe the limitations and challenge which is there in the study. So in the development study, they have mentioned that there's a lack of diversity in the population. And they have also mentioned that they couldn't collect more information about the patient characteristics. But they have said that this risk factor will be assessed in the RCT. Other challenge they have mentioned that these are online things, so you need some amount of digital literacy to actually access it. In the RCT, they have mentioned that people would have actually signed up less because of the digital, because everything is digital. If they're not comfortable, they may not have signed up. Some of the challenges they have not mentioned is they have not mentioned the training or any expertise of the patient before. They have not mentioned if any money was given. They have not mentioned any other measures they have taken or the time and the contribution of each person. They have not explicitly mentioned. They didn't have a representative from the underserved population there. So now to summarize of the ideas framework, this is for the development study and this is for the RCT. So actually, it was a well-reported study. Few things like the frequency, durations, remuneration was not given. I think apart from this, everything else is actually done. It's not reported. In the RCT, they have actually reported everything. And there also the form of remuneration is not mentioned. To conclude, it was a very adequate and a good reporting. Only few details were not reported explicitly. Now coming to the second part, how effective is it? So there's a good aid which is developed. Is it effective in our population? Now, to answer this question, I will be presenting this clustered randomized control trial, which looked at effective of this strategies or effectiveness of this aid for preventing stroke in patients with atrial fibrillation. Now, coming to a cluster randomized study. So, suppose there is a vaccine which will protect you from a disease. But however, it will also induce something called herd immunity. Herd immunity means you are not vaccinated with the disease, but because the person next to you is vaccinated, you get some immunity. So suppose this green are the people with intervention who got the vaccine, red are the people with control. If you randomize them equally to both the groups, there is a possibility that some of your control will get herd immunity and get immunized. So that is actually given in the dark green. So that is because of the herd immunity, they have got immunized. So if you actually do analysis, your efficacy of the vaccine will become less. That is actually because of a cluster effect. So you, for that type of intervention, you can do something called a cluster randomized study. You can randomize separately the vaccine and the control in a different cluster to both the groups. Here also there is some amount of herd effect, but it may not really affect your results. So that will reduce the time to the contamination. So coming to an example, this is a study done before impact AF trial. Now this study was done to look if any educational intervention will help patient improve their compliance to anticoagulation. So they had two groups of people. One is the blue and the red group. So those were the group who actually had years ago received the education intervention similar to that. Now at the end of the study, there were one group which had received before and one group which was not received, and they had given a repeat education intervention and they looked at the results. Now if you look at the blue and the red circle, 1 year, 6 months, there's not much difference between the intervention and the control. So they are the same cohort which had received before. So they are kind of normalized by this time. But if you look at the group which were treatment naive before, there is a difference, 42% versus 18%. So this was a cluster effect. So now this study, since this is also education intervention, they have done a cluster randomized study. So just to summarize, target population, eligible population randomized to two groups. In cluster randomization, you locate the possible clusters and you randomize the clusters into different groups. Same intervention and control. So this study was a 4-arm cluster randomized multicentral trial. It was done across 6 academic centers in US, and they had taken patients more than 18 years with a diagnosis which is diagnosis of non-valvular atrial fibrillation. Now, intervention arm was a decision aid, control arm was a usual care. They had 3 outcomes. The first outcome was a option 12 score. So that reflected the shared decision making. The score, it was scored from 0 to 100. The more the score is, the better the outcome. It tells you how much is the shared decision making. Second was a patient knowledge. So it was a 7-item true and false survey. So more the correct answers or more the score, the better the knowledge the patient has. The third was something called a decisional conflict. They looked at a decisional conflict scale. The lower the scale, lower the conflict. The lower the score was better. So option 12 score, patient knowledge score, and decisional conflict score. This to better the score, better the outcome. Here less the score, less the conflict. And this study, the timing was, this was taken immediately after the encounter. This is just to show the encounter and patient decision aid. The patient decision aid is the one they see before they see the doctor. This is the one they see when they see the doctor. So it explains in between just a basic of what is atrial fibrillation. It talks about do you need anticoagulation? So this is a risk factor which we do. It talks about the complication stroke. What is the chances? So here is a personalized your chance for them. And here the doctor can talk about patients who take medicines without don't take medicines. And this was a bleeding risk. So all blood thinners have a risk of bleeding. So this tells you what do you expect, and here that tells you how much is the bleeding risk out of how much it is. And final would be the preparation. So here would be like the questions you can think about to ask, and here would be you can actually enter the intervention and it can be copied to the whichever online event you see. And this was the one they used in the study. This was a patient decision aid. It looked like this, and encounter decision aid. Now coming to the CAS questionnaire, how were the patient randomized? So it was a electronic randomization by a red cap randomization. So there were the patients were randomized and the clinicians were randomized. They were randomized into intervention and the control arm. There were 4 arms. One arm was no usual care, no intervention. Second arm was both the decision arm. Third arm was PDA and the fourth was the EDA. So either both and no arm. And the primary outcome was done immediately after the survey. And that was satisfied by the Chadwell score and the patient cohort. So we had talked about initiation of monitor cohort, so that was the stratification data. Allocation, so they had a central allocation, it was well concealed, where all the patients are accounted for. So this is a consort figure. So this 19,629 were assessed for eligibility, 1,214 were randomized, and this were the 4 arms. So usual care, both the aids, either of the aids. So actually, if you look at both the aids, 17 were ineligible, but 19 had withdrawn and 10 had missed. So that had actually a 13% of loss to follow-up, which might be concerning. And the last encounter decision had around 9% loss to follow-up. That they analyzed in the group, yes, they were analyzed in the group. So they had taken only the people who had completed. It was intention to treat analysis, and study was not stopped early. Were they blind? Participant blind? Yes, participants were blind to the intervention given. Where the investigators blind to the intervention they were giving, so they had actually mentioned that each investigator remained blinded unless the plan was executed till the data completion was done. Outcome assessment. So the first option 12 score was a score which was calculated by the assessor by looking at the video encounter. So they had no way to blind it. So that probably would have biased in favor of the encounter decision aid. But other outcomes assessors were blinded. Were the study group similar? So this is a baseline characteristics. It was actually very well matched. The stratification which was they done was actually equal. Only difference was the positive for limited reading ability 11, 6, 7 that might not have made much of a difference. This is a baseline characteristic of the clinician prover that was also actually adequately matched. Apart from the experimental intervention, did they receive the same level of care? So they have not mentioned if they received any other difference. Apart from this, everything else they have mentioned as similar. There's no difference in the frequency of the monitoring. Sample size calculation. So here it's a cluster randomized study. So normally in each cluster, there is some amount of intra-cluster variability that is accounted by the intra-cluster correlation. So in this study, they had taken for the 3 outcomes separate ICC, and based on that, sample size was calculated to be 1200 for a 80% power with a two-sided alpha of 0.05. And yeah, so they had used they have not done a multiple comparison, they had used a gatekeeping strategy. Funding was central, they had no conflict, it was approved by the IRB. So looking at the internal validity, it was a very well done study. Apart from one outcome assessor blinding and some follow-up, it was a very well done study. Coming to the results, was the effect of the intervention reported comprehensively. So this is the 4 primary outcome by the randomized trial. So there are 4 groups, usual care, both the aids, either patient decision aid or the encounter decision aid, and this were the 3 primary outcomes. So option 12 score, more the score is better. Knowledge 7 score, that's a true and false, more is better. And decision conflict score, low is better. So less than 25, that's a good score. So this is just a mean, and this is the primary outcome results. So the first one they looked at both the aids versus the control. So in the primary comparison, they have given for each 3 outcomes separately. So for the option score, 12 score, actually all 3 were significant. 12.1% difference with a confidence interval of 8 to 16.2, 1.68 with a confidence interval on the same side, 1.35 to 2.09. And here in the negative, minus 6.3 from minus 9.6 to minus 3.1. So actually the primary comparison for this was significant. And actually the secondary comparison of each aid with the control were also significant. This was a subgroup analysis. All the subgroup was actually fair and more equally similar. They didn't find anything difference in the subgroup analysis. It was pre-planned. Now coming to the last part, was there any, did they report any harm or cause? So they have not reported any harm or cause. Only thing they have mentioned is they found that the sessions with the encounter decision aid were longer than the other session, but it is not that. This is one of the secondary outcomes, not significant. Will there be any effect on healthcare utilization and quality? That is something which we can't answer in this. Coming to the external validity, can it be applied to a local population? So are the participants similar? As we know, so we know that European descent, the physiology similar, they have more non-verbal AF than us. Would any difference between study your population and the participant altered the outcomes? Probably not. I think the response toward online decision aid probably must be the same. How are they different from us? Maybe our decision, our digital literacy may be different and our access to the tools might be different. But otherwise, this can be actually applicable to our center. Are the outcomes important to our population? Yes, we also will get patients with atrial fibrillation with risk for stroke. Are there any other outcomes which you would have wanted? So looking at the patient cohort, we compared to them, our non-valvular AF might be less. We get more of a rheumatological, valvular rheumatic heart disease, procedural heart disease. And other outcomes, they are not looked at clinical outcomes, mortality, stroke prevention. That's something they are not looked at in the study. But are there any limitations of the study that would affect your decision? No. Would it provide a greater value to your people in your care than any of the existing interventions? Yes. So the resources they needed, at least they had mentioned, was a digital platform, which we already are using. A personalized version was the one which given for the patient thing, and they had wanted training of the clinician. Are you able to disinvest resources in one of the existing interventions? So this may be a probable just an add-on first, and in the long time, it might be cost saving. If you prevent a stroke or a mortality, it might be cost saving in the long term. Now coming to our patient with atrial fibrillation who has problems with compliance and who's a very educated man, will I use this tool? Yes, I would suggest. I would definitely advise this tool. And IDEAS framework has shown that this has good, well reported patient and caregiver outcomes. Thank you, sir, for teaching me.